Good day. My name is Sister Mary Benedicta Maier, and I'm happy to be presenting on my capstone topic of frailty and dementia. Does mechanical or manual feeding make a difference? Personally, I have become interested in the topic of dementia as we care for two of our sisters who broadly have dementia, one with early onset Alzheimer's and the other with dementia. Additionally, in my current service at a health system in Tulsa, Oklahoma, I've witnessed how a dementia diagnosis can be quite difficult. It was these experiences that propelled me to study dementia and nutrition as my capstone practicum and paper. The objectives of the practicum side of my project were as follows. 1. To analyze the medical factors that go into the decision to pursue tube feeding over spoon feeding. 2. To define and describe the medical complications of tube feeding and how they might differ in a patient with dementia versus one without dementia. 3. To explore how people's frailty is affected comparing their method of feeding, and if there is any noticeable difference in the patient's frailty that could be considered a cause of the change in their feeding method. And 4. To more fully understand how a dementia diagnosis affects patients, their family members, and medical staff. In order to analyze these objectives, I chose the 5-box method, a version of the 4-box method that includes the Catholic perspective. It is an ethical decision framework that lends to the integration of many factors. The 4 categories that are studied are medical indication, patient preferences, quality of life, contextual features, and the 5th, the Catholic context, is incorporated into all the other 4. It wouldn't be a healthcare presentation without some statistics to situate dementia. There are approximately 50 million people in the world with dementia, over 5 million of them being in the USA. 40% of people aged 85 or older in the US have dementia. People with dementia are important to healthcare institutions in part for the very reason that they are approximately 25% of hospital patients ages 65 and older. The healthcare industry, as we know, is a massive percentage of the economy. In 2013, it was estimated that the yearly monetary costs per person that were attributable to dementia alone in informal care was between $41,689 to $56,290. The amount purchased in the market was $159 billion to $215 billion as of 2013. And it is estimated that these numbers will double by 2040. With these imposing statistics in mind, it should come as no surprise that protecting the dignity of the vulnerable population is important for Catholic bioethics. People with dementia often are presented with ethical issues around the basic necessity of nutrition and hydration. While spoon feeding is the normal manner of consuming food, those with dementia may require tube feeding in order to maintain proper nutrition. Although the question of spoon feeding over tube feeding seems to be a basic medical question, in reality there are many factors that influence the decision toward assisted nutrition. What medical indicators are relevant? Are patients able to state their preferences? Is the decision made because of a quality of life judgment? Is frailty affected? Could the decisions have been made delayed if the facility offered rehabilitation or other resources? How does society respect those with dementia, or does it only see them as a burden? This bioethical dilemma is important to address as dementia is a chronic condition without a cure, and secular and Catholic teachings can differ as to the very basic goods of nutrition and hydration, especially for the vulnerable. Although I covered 4 patients in my capstone paper and would have loved to talk about them during this presentation, we'll only focus on one patient, patient D, for the interest of time. Patient D is an 83-year-old with dementia who is in the hospital with acute respiratory failure. He was a long-term nursing home resident. When the speech pathologist entered his room to feed him, she found that he had partially pulled out his Cortrax NG tube. The patient became more agitated by the nursing care when they pulled out his Cortrax completely and adjusted his head in bed. The speech pathologist, on the other hand, had a beautiful rapport with him, showing him dignity and speaking to him slowly while close to his head. In turn, he responded and was willing to eat some applesauce. His affect improved, and he was willing to move part of his head. The speech pathologist discussed future physical therapy of the neck with her colleague so that the patient could gain mobility in his neck in order to better swallow and eat more food by mouth. The varying approaches of the nursing and therapy staff members seemed to directly affect the patient and the care team themselves. Those who show dignity receive dignity in return. Catholic Church teaching recognizes a patient's self-determination, autonomy, or freedom to choose the true good. In terms of patient D, his ability to express his preferences was very limited. He could respond to speech pathologist's requests for spoon feeding. He could cooperate with some physical therapy. Because his body did not rest well in the bed, and his agitation was manifested, in part by pulling out his core trap, he eventually could not maintain the nasal tube. Physician and care team decided to seek agreement from his wife to place a PEG tube. Patient D required a feeding tube after his NG tube was repeatedly removed. One may ask, what is the point of his life? A judgment is made on the treatment as being beneficial or burdensome, not the life of the person. I personally noticed that healthcare staff and family members who approach patients with humor, love, and dignity often would find that the patient would be more compliant and pleasant in return. Patient D was married, and his wife was able to make decisions for him. While loving care and concern are often easier to pour out upon those who respond and are obviously loved in return, it is the vocation of the healthcare worker, especially within a Catholic health system, to have preferential love for the poor and the vulnerable. I noticed by shadowing dietitians and speech pathologists the importance to be willing to try modified diets with each change in muscle tone and each swallowing test. Watching the rapport with patient D in terms of a consistent feeder made a difference to the patient's affect, trust, and ability to wish to engage in eating. Bedside swallow tests take time and are tedious. They can save unnecessary testing and also can be more comfortable for the patient as they can be done in the patient's hospital room. Although it takes time, patients should be able to have swallowing rehab from the beginning so as not to lose their abilities. Incorporating family is critical, and extra care ought to be made by healthcare staff to show loving care to those without family support. Finally, NG tubes ought to be the first artificial means of nutrition, but if not possible, then feeding tubes. So it was decided that patient D needed a feeding tube. This decision fulfilled two fundamental principles of Catholic bioethics. One, to protect the vulnerable person, and two, nutrition and hydration are basic care, not normally extraordinary means. It also showed that the healthcare institution was willing to move forward with new decisions to support the health of the patient. Although these are overarching bioethical principles that need to be applied to all of these cases, a decision must be made on a case-by-case basis, as every human person is unique. The healthcare institutions seemed to choose the best course of action eventually because their decisions viewed each individual person, the patient, the family member, and the caregivers with dignity and advanced their flourishing. The decisions expressed above, too, were good because the judgments were made on the treatment, not the life of the person as being futile. I also found that patients tended to be more compliant when they were treated with dignity, and staff were happier too. The institutional ethos seemed to be stronger when the elderly were viewed through compassionate eyes, that they had much to say and to give to society. To conclude, patients with dementia are faced with difficult questions regarding their care, especially surrounding the matter of feeding. Whereas spoon feeding is the natural means of receiving nutrition and hydration, sometimes feeding tubes are needed in order to ensure adequate nutrition and overall health. It is difficult to conclude if there is a direct cause and effect to changes in patients' feeding from spoon to modified diet to feeding tube, especially when the feeding tube is medically necessary and not a result of a hastened medical decision or a result of lack of resources. What is often palpable is the change in the care staff and the institution when they show compassionate care and treat the patient and family with dignity. This is when healthcare is truly merciful. I would be gone amiss if I didn't extend a note of gratitude, and then we'll have a time for questions. I would like to thank the University of Mary faculty, staff, and colleagues for their teaching and support. Also, my 2 practicum sites in Tulsa, Oklahoma, and finally to my community, the Religious Sisters of Mercy of Alma, Michigan, who have sent me here for these studies to be of service to the church. Thank you very much, and I'm now available for questions. Thank you.